20 20 years old female presented with shortness of breath and cough.
العفو دكتورة، قلت لي فيميل مو 20 سنة.
Okay. 20 years old female with cough and shortness of breath.
مم. نعم. axial CT scan of the chest shows innumerable tiny cysts in the distributed over all whole lungs bilaterally,
نعم.
more in the upper and left lung.
مم.
And with the طبعا اكو interlobular septal thickening.
نعم.
The cysts are small يعني sub centimetrics. واكو left sided pneumothorax ايضا. حركي والله دكتورة بعد زين. شكله شو اسمه، مو بس نيمو، يعني هايدرو نيموثوراكس. left sided هايدرو
نعم.
نيموثوراكس. هايدرو
نعم.
نيموثوراكس. ايه تمام. كانت هنا
اكو اير فلويد ليفل، فاكو هيدرونيموثوراكس. نعم.
هايدرو نيموثوراكس. نعم استاذ.
زين.
طبعا استاذ، هو احنا اذا سيستيك لانج ديزيز نخلي ببالنا
اي.
كم شغله، بما انه فيميل، هي
اي.
فيميل، وبما انه اكو نيموثوراكس، فنخلي اول شيء لام ليفانجولايومايوماتوسيس.
نعم.
ونخلي اللانجر هانز، ولا اللانجر هانز لازم سموكر، واكثر شيء ميل. لانجر هانز سيل هيستوسايتوسيس.
نعم.
ونقدر نخلي الانفيزيما همين. بس يعني
نعم.
هو يعني اللنج انا اشوفه يعني مو كلش انفيزيميتس. بعد الاذر ديفرنشالز نقدر نخلي الليمفوبريتيف يعني لنج ديزيز او ديسوردرز.
نعم.
يعني هو اكثر شيء هو اللام واللانجر هانز سيل.
شنو الكوز مال الهيدرونيموثوراكس؟ هو انترنسيك بارت اوف ذيس ديزيز لو شنو؟ برايه.
هو باللام هو يصير كايلو ثوركس، يعني
كايلو.
يصير ليمف
نعم. هسه انت
اب
عندك
نورمال.
عندك
اي.
هيدرونيموثوراكس.
اي.
نعم.
يعني هو اللي تصير البريفرال بليبس ممكن تصير بها شو اسمه رابتشر.
ممكن بليبس ويصير بها
اي
رابتشر. زين.
رابتشر.
الفلويد منين اجى؟ هاي صار نيموثوراكس البليب.
هو كايلس وهايدرو، هو كايلو ثوراكس، يعني ممكن يصير
نعم.
باللام. اي.
يعني
اللي هو
قصدك
هو
انه هو البليب طقت والكايلس هو الديزيز. زين، هاي
هو
وحده بعد.
اي. يعني شلون قصدك سؤال بعد كوزس مال النيموثوراكس
اي. هذا المريض.
بهذا المريض؟ يعني هو البليبس مثل ما قلنا، او السيستس صار
اي.
بي يعني فيستولا. abnormal proliferation of هذا الليمفويد تيشو
نعم.
يسوي الكايلوثوراكس.
نقدر بالسي تي نعرف الكايلوثوراكس محمد؟
استاذ هو صعبه، هو هايدرو
يعني نقدر نعرفها من خلال السي تي دنسيتي لو ما نقدر؟
يعني هو الدنسيتي استاذ هو ممكن يفرقنا شو اسمه الهيمو عن بقيه الهايدرو، بس الهايدرو
نعم.
نفسهم بيناتهم اذا هو فلود عادي او هو كايلس يعني اشوفه صعب، ما ادري ما اعرف
نعم.
يعني صعب.
وات از نيكست بهذا المريض محمد؟ يعني شو نسوي له؟ فيش فيه له هاي كافي وصلنا الدايجنوستس ونعطيه
لا
تريتمنت؟
لا هو مو دايجنوستيك،
نكتب لهم
اكيد مو دايجنوستيك.
احتمال هذا او هذا.
احتمال هذا او هذا، هو مو دايجنوستيك استاذ، هو يعني
زين.
شوف النيتشر مال البلورال فلويد
نعم.
اسبيريشن
يعني
لازم
نسوي
نشوف.
اسبريشن للبلورال فلويد. نعم. لا
اي لازم
كايمجنج
نشوف
نحتاج غير شيء
النيتشر
بعد كايمجنج.
كايمجنج.
نعم.
يعني ما اتصور بعد يفيدنا شيء.
نعم.
هو
يعني هو
السي
السي
تي
تي. نعم.
وبس، هو مو ديفينيتيف دايجنوز يعني. الايميجنج بشكل عام بهذا الكيس يعني استاذ ما راح يفرق انه هو الكلينيكال لازم
نعم.
وياه
هي
كلينيكال والاسبيريشن.
طيتنا كلينيكال. هي عنده مسوي له اسبريشن.
اي هو مسوي له اسبريشن وطالع كايلوس
نعم.
previously لان هي
نعم.
recurrent attack of pneumothorax.
نعم.
نعم. هو النيموثوراكس
نعم.
وكلينيكال ونيموثوراكس والسيستس هي والكايلوثوراكس تمشي ويا اللام
نعم.
اكثر شيء.
احتمال هم يعني هو البرايمري ريبرزنتيشن مالته نيموثوراكس مينا.
هو نيموثوراكس هو اجى shortness of breath سوى له سي تي ويعني شفنا نيموثوراكس previously يعني كان
ليفت
هسه اجى.
ابر لوب ليفت ابر لوب اي يعني هو ليفت ابر لوب رايح يعني
نعم.
ما اكيد شورتنس اوف بريث
نعم. شكرا محمد. يلا
بالذات.
مين احكي لنا على الكيس وروحي على تويته. يلا
young age
تفضل
female
مين.
presented young age female presented with shortness of breath. CT show multiple small rounded cystic lesion with normal intervening lung parenchyma with left-sided hydropneumothorax. By taking her history, she had previous attacks of shortness of breath with same CT appearance. Pleural aspiration was done to her and show chylous effusion. So picture goes with lymphangioma. A lung cyst is a gas-filled structure with thin perceptible wall, typically less than 2 mm in thickness, but can be up to 4 mm. We can differentiate it with cavitary lesion, which show thick wall and irregular. So to know the cystic lung lesion, we have to ask if it's a true lung cyst or not. If it is not a true cyst, by definition of cyst, we think of cyst-like lesion like bulla, emphysema, honeycombing, and other differential. If it is true cyst, we should see if it's incidental or no. If it's not incidental finding usually rule of 4 and 40. Up to 4 cysts at age of 40 years is considered incidental. If it is not, we think of differential diagnosis. The association with the cyst, if there is nodules, we think of Langerhans cell histiocytosis. If there is ground glass in the lung, we think of lymphoid interstitial pneumonia or desquamative interstitial pneumonia. If there is no nodules or no ground glass, we think of lymphangioliomatosis. So, simple true pulmonary cysts usually have smooth, thin wall, while cavitation have thick, irregular wall, like in TB, malignancy, or vasculitis. Emphysematous bulla usually have no wall, and nematocele usually have a history of trauma or ventilation paratrauma. Here we have a true cyst with thin wall. Cavitary lesion have thick irregular wall, and emphysematous bulla usually have no wall, while nematocele have a history of trauma. If it is multiple, usually small true cysts have thin wall, emphysema have no wall, honeycombing usually have pleural-based and comes in rows, while cystic bronchiectasis, as we scroll, we see its connection to the bronchus. In step 2, it is an incidental finding. In young patients, lung cysts should not be regarded as a normal finding, and the rule of 4 should not stick to it too tight, as if the patient has a history of recurrent pneumothorax or have a family history and screening scan for Birt-Hogg-Dubé. For differential diagnosis, as we said, we see the association with nodules or ground glass. We also should see the cystic pattern, distribution, and patient characteristic. Here we have nodules with the cysts. We think of Langerhans cell histiocytosis. Ground glass, we think with lymphoid interstitial pneumonia or desquamative interstitial pneumonia. If there is no nodules and no ground glass, we think of lymphangioliomatosis. In cyst pattern, Lyme disease usually have thin wall, round, or oval, while Birt-Hogg-Dubé have preseptal, lenticular, or triangular shape cyst. Langerhans usually irregular, bizarre shape cyst. Lymphoid have vascular indentation, while if there is Cheerio sign, we think of Langerhans cell histiocytosis. Ground glass, we think of lymphoid interstitial pneumonia or desquamative interstitial pneumonia. Distribution of cysts, Lyme disease usually diffusely distributed, no lobe predilection. While in Langerhans, usually upper lobe, Birt-Hogg-Dubé and lymphoid and desquamative interstitial pneumonia have lower lobe predilection. Patient characteristic, usually Lyme disease come in women in childbearing age associated with angiomyolipoma, tuberous sclerosis, and spontaneous pneumothorax. Langerhans usually in smoking patient who there is high risk of lung cancer. Birt-Hogg-Dubé have a spontaneous pneumothorax and there is renal cancer. Lymphoid interstitial associated with autoimmune disease, especially Sjogren and HIV patient. Desquamative is a smoking-related disease. Lymphangioliomatosis is an indolent progressive disease exclusively seen in women as a sporadic genetic mutation unless associated with tuberous sclerosis complex, which can be sporadic or inherited. Patients usually are symptomatic with cough and chest pain. Some patients present with spontaneous pneumothorax, pleural effusion, usually chylus or angiomyolipoma. Two variants are associated with the disease, sporadic and tuberous sclerosis associated. Sporadic is almost exclusively seen in female. Although lung cysts consist of LAMP can be seen in males with tuberous sclerosis, they are rarely symptomatic. In CT scan of Lyme disease, we see large lung containing scattered thin wall, rounded empty cyst. In the early disease, the cysts are few and small. As the disease progresses, they enlarge and become more numerous until there is little normal lung remaining. Transient area of increased lung opacity due to hemorrhage, and we see small lung nodules representing multifocal micronodular pneumocyte hyperplasia, maybe see lymphadenopathy, chylus pleural effusion, pneumothorax, and dilated thoracic duct. Here we have a case of Lyme disease associated with thin wall cyst, rounded, and pleural effusion. Lyme cells may lead to blockage of lymph cysts in the chest and create chylus pleural effusion. Lyme is the only cystic lung disease in which we can see the combination of cyst and pleural effusion. The prevalence of angiomyolipoma in Lyme disease is 40–50%, while in tuberous sclerosis is up to 80%. Lyme is a poor prognosis disease. Langerhans cell histiocytosis is a rare idiopathic cystic interstitial granulomatous lung disease seen almost exclusively in cigarette smoking, and it comes in both sexes. Patients at an increased risk of lung cancer usually start as nodules that cavitate and transform to cyst, which is bizarre in shape. Here we have cases of Langerhans cell histiocytosis with the bizarre shaped cyst, upper lobe predilection associated with nodules. Lymphoid interstitial pneumonia is an interstitial lung disease of unknown etiology that characterized by infiltration of lymphocyte. It's associated with systemic disease, especially Sjogren. It can present as a simple cyst only, but more often in combination with the ground glass and reticulation. Here we have cases of lymphoid interstitial pneumonia. We have a cyst on ground glass opacity and reticulation with dot sign that resemble emphysema. Desquamative interstitial pneumonia has a strong association with smoking, usually present as symmetrical cyst within the area of ground glass opacity, usually predominantly in the base and the periphery. Although the distribution typically peripheral, they may also be seen in a random diffuse distribution. Here we have a cyst in the lower lobe on the area of ground glass associated with fibrosis and bronchiectasis. Other cases of desquamative seen cyst in the area of ground glass and fibrosis. Birt-Hogg-Dubé syndrome is a autosomal dominant disorder with 25% risk of renal cancer, usually asymptomatic but may present with recurrent pneumothorax. The cysts have a lower field and peripheral predominance. They typically less than 50 cysts. Here we have a pleural-based cyst in the lower lobe with a septal appearance. Thank you.